ahead,
Good evening,
Sivathanu.
sir. Good evening, sir. My question is, a 65-year-old male with a history of diabetic mellitus for 20 years, posted for the treatment of infected food. He had a patient is febrile, tachypneic, and drowsy. Discuss the management. Since he had a patient is critically ill, and since the patient is drowsy, I will go with ABC approach here. I look for airway patency and heavy snoring, and then breathing. I will look for the chest movements, respiratory rate, and the auscultation, bilateral air is present or not. And then the SpO2, if it is low, we have to start oxygen therapy at this time. And with face mask O2. And if the persistent hypoxemia is present, or any airway patency is not there, or any airway reflux absent, then we have to intubate the patient, mechanically intubate the patient. And then circulation, we look for heart rate and blood pressure, and we have to assess the peripheries, any cold peripheries, and the capillary refill time. By this time, we have to start a IV cannula and send the blood for lab investigations, and to start the fluids, crystallized 0.9% in normal saline, 30 ml per kg within the first hour. And then the disability, here the temperature is raised, and we have to assess the GCS and the pupil reaction for brain perfusion, and the random blood sugar have to be obtained. If it's high, send the ABG and serum ketone. If not ABG, then BBG also. And along with the investigation, we have to send the lactate, CRP, and procalcitonin and proconine I also. And then we have to look for the wound exam, local examination of the wound. From the brain survey, my differential diagnosis will be the patient have sepsis. My first diagnosis will be the patient has sepsis or septic shock with a multi-organ failure. And the second is a patient have the diabetic ketoacidosis or glycemic hyperosmolarity coma. And the third diagnosis will be the patient have AKA with uremia with electrolyte imbalance. And the fourth diagnosis, the patient will have the acute myocardial infarction with a cardiac shock also. And the patient have the fifth diagnosis, the ARDS. And my last is patient will have the hypoglycemia. It is a distribution by the point of care glucose testing. Then the management, first the instance of disease management. First, we have to establish the patient that the patient plan for surgery is an emergency. Go that we have to shorten first initial stabilization of the patient. First, we have to manage the sepsis, and the initial first hour bundle we have to follow. We have to start we have to obtain the blood culture, and we have to start a broad spectrum antibiotics. And the common choices include the piptas, meropenem, and vancomycin. And we have to source control that the surgical deployment to be done. And then we have to maintain a glycemic control and organs support, ventilator support for respiratory failure, and renal replacement therapy if the patient is AKA, and nutrition therapy. The steroids, if there is a persistent patient remain hypertension despite adequate fluid vasopressure given, and 200 mg per day in divided doses. And our second is there's a patient with the sugar is high, the patient may have DKA or glycemic hyperosmotic coma. First, we have to differentiate between the two. Diabetic ketoacidosis, the blood glucose is more than 250 milligrams per deciliter, and arterial pH is less than 7.3, and bicarbonate level is less than 18, and ketones is more than 3 millimole per liter, and the serum osmolarity is variable. Right, a hyperglycemic hyperosmotic coma, where the blood glucose is more than 600 milligrams per deciliter, the arterial pH is more than 7.3, and the bicarbonate is more than 18, and the ketones negative, and serum osmolarity is more than 320 milligrams per deciliter. Then we have to manage the diabetic ketoacidosis. By initial, we have to start IV fluids, 0.9% that we already started with 1 to 1.5 liter within the first hour. And then we look for potassium. If the insulin substance is stopped there, if the potassium is less than 3.3, if potassium more than 3.3, we can start the insulin with the IV stat 0.1 unit per kg, followed by 0.1 unit per kg per hour infusion. And after the 1 hour, we have to look for the corrected sodium. The corrected sodium is equal to serum sodium plus 1.65 into blood sugar minus 100 divided by 100. Subsequent fluid will be based on the corrected sodium. If the subsequent corrected sodium is still low, we can convert it to 0.9% NS. But if it is high or normal, we can go with half normal saline up to 250 to 500 ml per hour. Then after 1 hour, if the blood sugar is less than 250 milligrams per deciliter, in the diabetic ketoacidosis are less than 300 milligram per deciliter in hyperglycemic hyperosmotic coma, then you have to start at 5% dextrose with a half normal saline. And then we have by the time now we got to look for the investigation that is done at the time of initial presentation. We have to look for HP, and the total count is raised, and CRP will be raised, which must be reduced to the infection, and then the serum urea, creatinine, to look for a renal perfusion, and it's a AKA or any CKD. Now AKA superimposed on CKD, and the electrolytes, and the serum trophy for look for any myocardial depression, and procalcitonin, and amylase for pancreatitis, and the ECG, and the sexual state for look for any aspiration, pneumonitis, and blood clotting and typing, if possible, echo or HbA1c. Then we have to go for secondary survey pre-analysis evaluation. We have to ask the history. What is it? We have to first infant type of diabetic mellitus, and for duration of diabetic mellitus, and whether these are insulin or oral hypoglycemic agents, and the compliance of the therapy, and any previous admission, ICU admission for increased random blood sugar. And then we have to ask the complications. There's a macrovascular and microvascular complication. There's a history of any myocardial infarction, stroke, peripheral vascular disease, and then any visual changes, any history of any reduced urine output, and any most important is positive hypotension, any autonomic neuropathy is there, and we have to ask other comorbidities, and there's a airway examination have to be done, and fasting status, and allergy status. And finally, we have to give the anti-aspiration prophylaxis. And then the plan of anesthesia. This is two possibilities: regional and general anesthesia. Regional, most frequently nerve blocks, complicated sciatic adductor canal block can given. And the advantages: the patient is conscious, early detection of hyperglycemia, and a reduced surgical stress response. But a disadvantage, the patient have to coagulate the nerve will be high, the chance of infection will be more. And in GA, we have the general anesthesia with endotracheal intubation. That's a rapid sequence injection. Given the sepsis-induced gastroparesis and the risk of aspiration, and ethambutol if the patient is stable and will unstable, and propofol 1 to 2 mg per kg. If not, and relaxation is rocuronium with the 0.9 to 1.2 milligram per deciliter. And anesthesia fentanyl 1 to 2 mics per kg, and with the maintenance with Tiva infusions. And intrafluid management, we have to continue the crystallite resuscitation guided by the hemodynamic parameters, and vasopressor support to be continued and titrated, and intrafluid urine output monitoring has to be done, and the patients should maintain the normal thermia of warming blankets and warm IV fluids. And it's a post-op care, it's a O2 supplementation, and the ICU admission for continued monitoring, sepsis, glycemic control and organ support, and pain management by IV paracetamol and opioids, and we have continued antibiotic therapy, and the frequent blood sugar monitoring, and monitoring for complication, acute kidney injury, acute respiratory distress syndrome, multi-organ failure, and wound infection. Thank you.
Very good. You have thought of so many differential diagnoses in this case because of the three wordings that have been given. Patient is febrile, patient is tachypneic, and patient is drowsy. Okay?
Yes, sir. Yes, sir.
Now, have you ever made any attempt to find out what treatment the patient has been taking before this problem happened?
It's a possible diabetic mellitus. Sir, pardon, sir. Question, pardon, sir.
Did you find out from the history what treatment patient has been taking all along? Because the diabetes duration is 20 years.
20 years, diabetic.
Isn't it?
Yes, sir.
So, what is the importance of taking the treatment history in this case?
Because it's a long-standing diabetic, the patient can have that patient have autonomic neuropathies, and the patient have wound healing, and the patient now the patient becomes insulin dependent. There's a poor compliance, so accelerated more mortality and morbidity during surgery.
Very good. So if supposing patient has been taking insulin also, how are you going to
Yes, sir.
manage the insulin regimen?
Sir, short-acting insulin have to stop on the day of surgery, sir.
Hmm.
In the long-acting insulin, we put a BD dose. It's a BD dose. We can continue. Previous day morning, we can give it a full dose, sir. And the night, we can reduce cut up. We can give almost 80% group. And the next day morning, we have to cut up the insulin, sir.
Hmm.
And it's a long-acting insulin. It's a in BD dose. We can continue previous day morning. We can continue the full dose, sir. And night we have to stop. We have to night and next day morning we have to stop, sir.
So even if he is on a mixed insulin, you will continue with that.
Mixed insulin we can only stop and that part, sir. Short-acting insulin we have to stop and we can continue the long-acting insulin, sir.
What is the role of insulin analogs in this case? What are insulin analogs?
Sir, sulfonylureas, sulfonylureas.
Insulin analogs? Is it? Anybody else who can answer that? What is an insulin analog? Now, if this sort of case scenario is given in the examination, there are two ways of questioning. Examiners can completely ask all the questions regarding the diabetic medical problem or medical
Yes, sir.
pathophysiology, what is glucotoxicity, how to manage diabetes. That can be completely threadbare question. Other management is dividing it into the complications of long-standing diabetes and an acute complication like which looks like a DKA in this patient. The patient with an infection is always prone for diabetic ketoacidosis.
Yes.
More than what we have suggested as a differential diagnosis like aspiration going in for ARDS or septicemia, the most probable problem of this particular patient is a DKA. Okay?
Yes.
And DKA, what are the types of DKA nowadays we talk about? Earlier, when we were telling about diabetic ketoacidosis, what are all the features which were included in diabetic ketoacidosis?
Hyperglycemia,
Hyperglycemia, ketoacidosis, and
metabolic
acidosis.
acidosis.
Okay, these are the three things. High blood sugar, which is hyperglycemia, more than 350 milligram, ketonemia, more than 3 millimoles, and acidosis, pH less than 7.3. Okay, these were called as a classical diabetic ketoacidosis. Nowadays, we have conditions where blood sugar is less than 250, but still patient has ketonemia and acidosis. What do you call that condition?
Hyperosmotic.
Non-diabetic ketoacidosis. Non-diabetic ketoacidosis.
It's called non-diabetic or some other terminology is used.
Euglycemic.
It's called euglycemic. Yeah, Sri is right on the bank. Called euglycemic diabetic ketoacidosis. Okay. And which condition produces this euglycemic diabetic
The
ketoacidosis?
patient is not taking on SGLT2 inhibitors.
SGLT2, very good. That is the one drug which is now being very, very popularly prescribed by the diabetologists for many cases. That is notoriously famous for producing euglycemic diabetic ketoacidosis. Now, what is the difference between the normal hyperglycemic diabetic ketoacidosis and euglycemic ketoacidosis? What is the difference in the management?
Sir, management it's an insulin not it needed, sir.
First normal saline.
You have to kind of consider degradation. We can correct in the degradation.
The chances of hypoglycemia is more in
More.
hyperglycemic diabetic ketoacidosis or euglycemic?
Hyperglycemic, sir. Hyperglycemic.
Hyperglycemic, if you is pumping too much of sugar, I mean insulin without proper calculation, then you can land up. But the euglycemic patients are more prone for hypoglycemia with your insulin therapy, and sometimes they may require glucose containing IV fluids rather than your normal saline which you give for your diabetic ketoacidosis. Okay? And now with the diabetologist prescribing SGLT2 inhibitors rapidly for all diabetic patients, euglycemic diabetic ketoacidosis is becoming more and more common than your regular hyperglycemic diabetic ketoacidosis. And that is the reason why I wanted you to ask for the drug treatment or the therapy that the patient has been taking before they landed up with this particular problem. Okay? Now coming to the exact pathophysiology of diabetes, how does the diabetes cause all these complications? You said microvascular and macrovascular
Yes,
disease.
sir.
Okay?
Yes, sir.
So how is this vasculature getting affected in diabetes? What exactly happens?
Because of the advanced glucose glycosylations, because SS sugar forms advanced glucose glycosylation that produces endothelial injury.
What is advanced? How do you define this advanced glycosylation end products?
end products, non-enzymatic with glycosylated with the proteins and fatty acids. Excess
Excellent,
glucose.
very good. So what do they do?
They produce the reactive oxygen species. Between blood vessels, they produce endothelial injury. So the activation of the coagulation cascade, platelet and the lipid activation. So this leads to other diseases and all the major stroke in me and
Okay. So these advanced glycation end products, is it only present in diabetic patients or is it common to some other diseases also?
Thyroid.
Alzheimer's.
Yeah, it is a common pathophysiology which causes diabetes, kidney failure, cardiovascular disease, Alzheimer's, and skin changes and aging. So it is a product or adduct which is called actually advanced glycation end products can be exogenous as well as endogenous. Okay, and they are present in several disease conditions, not only in diabetes. But in diabetes, they are very pronounced because they produce this micro and macrovascular inflammatory changes after they are formed because of the excessive glucose that is present in the body. So now they have found out these advanced glycation end products are responsible not only for producing diabetes but also the other diseases, and they are now trying to reduce the amount of these AGEs produced by both endogenous and exogenous by lifestyle modification, food intake, and other vitamin supplementations. By these methods, they are trying to reduce the formation of this particular thing. Okay? So this is a very important pathophysiology that you have to know about this glucotoxicity, which is responsible for all these changes that happen. So the drug treatment, why it is important? Because when you want to take up this patient for wound debridement, whatever type of anesthesia you wanted to do, you must know whether to continue with the medication or stop them altogether or alter their dosage or alter their time of administration. That is a very important thing that we have to know. So for that, you must always make sure that what is exactly the drug treatment the patient has been taking. Usually patients who are maintaining their glycemic control with oral anti-diabetic agents, what will happen to their blood sugar if they develop an infection like this in the food? Will the blood sugar be normal or reduced or become
High.
highly?
it's hyperglycemia.
They will develop very high blood sugar which cannot be controlled by the oral medication which they have been taking prior to developing this infection. Okay? Any stress or any infection, always, why do they increase the blood sugar? What is the mechanism by which their blood sugar gets abnormally elevated when there is an infection?
Because glucose production in during stress, the counteracting hormones levels in rise, glucagon and adrenaline which increase the glucose production, so hepatic glucose production, through
Okay.
gluconeogenesis and glycogenesis.
Very good. So this any other mechanism? One is glucose production is increased. Second is counter-regulatory hormones are increased. Any other? What happens to insulin? Will it be able to
Insulin
act
level is
endogenous insulin?
endogenous insulin level will decrease.
We
Resistance.
develop insulin resistance. Okay. So that is also one of the factors for the blood sugar level going up. So that is the reason why we give exogenous insulin, because endogenous insulin is not able to control. So you try to control the blood sugar by exogenous insulin. What is the role of continuous insulin infusion? When will you resort to continuous insulin infusion?
It's more than 24 hours. A patient came in fasting, patient we kept in fasting, that kind of conditions. We can
Liver transplant.
continuous.
What are the other indications for continuous insulin infusion? Other than
Liver,
huh?
liver transplant, sir, and cardiopulmonary bypass.
Hmm.
And pregnancy.
Pregnancy,
Type
neurosurgery, and organ transplantation. Okay, these are the three conditions
High blood
which
sugar
require
control, sir.
continuous insulin infusion to keep the blood sugar preferably
140.
under what level?
110 to 140.
140.
120 to 200. That's what the safe limit claim is. 120 to 200 or 120 to 180 rather will be the ideal range at which you should control these sugars by giving insulin infusion. Okay. So what will be your advice if the patient has been taking, say, glimepiride and oral SGLT2 inhibitors and metformin? If these three are the drugs the patient has been taking, what
The
would be your
sulfonylureas,
advice?
sir, the sulfonylureas we can stop on the day of surgery, sir.
Ah,
And for metformin, we can should they continue on the day of surgery, sir.
what
Because
is the risk of taking metformin?
Lactic acidosis.
Lactic acidosis is one of the complications which can worsen the acidotic state. Okay, so this is to stop metformin. SGLT2, what is the recommendation?
You have to stop at least 48 hours before the surgery, sir.
Before
Because even profuse degranulation, the profound degranulation, the patient can go for a severe hypotension in the operating.
Very good. So you mentioned only about the nerve blocks, the sciatic nerve, not you will say sciatic, you said operator and adductor canal block. What other block you said?
Sir, popliteal, sciatic, adductor canal block.
Popliteal, operator and the sciatic canal block. Adductor. Why not spinal or epidural injury?
Since a patient is septic,
Patient?
patient in septic, sir, to
Sepsis, there is a contraindication for epidural, but is there contraindicated for single shot spinal also?
No, sir. We can give a single shot spinal load.
The majority of them agree with the single shot spinal
Right.
also. It depends on the surgeon's speed and the duration it takes. What is Wagner's classification of the wound? Have you heard of Wagner's WAG?
Yes, sir.
Wagner's classification of the wound. What is the importance for us as anesthetists to that?
They did surgical or only for closure, the graft taken.
It shows the different degrees of tissue damage. Okay, the Wagner's classification of diabetic wound describes the various depth or degrees of wound damage that happens because of the diabetic infection. It is superficial, the skin and subcutaneous tissue, the fascia is called grade 1. If it goes to the ligament, to the bone, with no abscess formation, it's called grade 2. If there is an abscess formation and deep down to the facial level, it's called grade 3. If there is a partial gangrene, it's called grade 4. there is an extensive gangrene, it's called grade 5. Okay? So depending upon the depth and the damage to the tissues, it may be a simple excision of all the necrotic tissue, allowing it to granulate and then put a graft later on, or it may be uh, amputation if it is grade 4 or grade 5 with an extensive gangrene itself, which has already completely become devitalized. That tissue, there is no point in retaining it. So this Wagner's classification helps in identifying the type of treatment the surgeon may offer. And based on the treatment only, your anesthetic technique is going to be planned. Okay? Because longer the duration of surgery, you need a longer duration of anesthesia, which can be achieved only by a continuous epidural or a continuous spinal or a GA. These are the three techniques which can give any length of time of anesthesia for the surgery. Okay? And here being an infective focus, epidural is contraindicated or not preferred because the chances of epidural abscess are more with try an epidural. So single shot spinal will be okay, but if the duration is going to be longer than the duration of the block, that also is going to cause problem. Then you have to go for GA. So what are all the other systems that have to be evaluated before you plan for anesthesia in this case? With a 20-year-old history of diabetes, what are all the systems you have to evaluate?
Sir, it's a cardiovascular system.
Huh?
Cardiovascular system, sir.
Cardiovascular system. What is the most notorious complication in the cardiovascular system known in diabetic patients?
Myocardial infarction.
Diabetic?
Myocardial infarction.
Cardiovascular complication.
Myocardial infarction, sir.
What type of myocardial infarction?
Silent.
Silent myocardial
Silent
infarction.
one.
Okay. What is the difference between normal myocardial infarction and silent myocardial infarction? Why they are silent in diabetic patients?
Sir, because here the autonomic nervous system damage is there, sir. So that the leaking electronic stimulator pain receptors will not work here, sir. The transmission will not be there, sir. The patients will never feel the sensation of pain, sir.
The patients who have already developed diabetic neuropathy also, they are the ones who will suffer from diabetic silent myocardial infarction because the nerves are not able to transmit the brain stimulation. They don't feel the tangential pain that normally happens in a patient with myocardial ischemia or infarction. And that is the reason why they silently go for this infarction, extensive damage, and sudden death can happen. Okay? And if there is an autonomic neuropathy, what is the most important precaution you will take? How to assess for the autonomic neuropathy in a diabetic patient?
The orthostatic hypotension, sir. Posterior
Very
hypertension.
good.
History of and the importance that the patient we are more prone to hypotension, sir, during injection. So we have to titrate the drug before in GA. Spinal has to be reasonable, by spinal has to be avoided, sir.
No. I'm asking how will you diagnose diabetic autonomic neuropathy in a patient?
The patient have a resting tachycardia.
Only you said is postural hypotension. That's one symptom.
Valsava manual hand kit test, sir, and resting tachycardia.
He's a male patient, so what else he can complain of? You can classify that into symptoms and signs. First, say what are all the symptoms the patient may complain of if they have diabetic neuropathy.
Sir, it's tachycardia, palpitations, sir, and then have some sexual dysfunction, sir.
So, erectile dysfunction, constipation alternating with diarrhea, bowel disturbance, sweating problem. They may not have adequate sweating or excess sweating may be there. Then they may have this giddiness on getting up, which is postural hypertension. Okay, so these are all the symptoms that they may come with. And signs objectively, you can do a Valsalva and then try to find out the offshoot or the end point where there will not be a return back of the heart rate to the normal at the end of phase 4. And any other method of this is one of the theory questions they may ask you. For the sake of juniors, I am asking this question. Assessment of autonomic neuropathy. It's one of the repeatedly asked theory questions. So at least you must know the few points to write about that. Okay. Right. What about the renal involvement?
Sir, renal, that
What
patient
is
can
diabetic nephropathy? What happens in diabetic nephropathy?
diabetic nephropathy, the patient, because of the lipid peroxidation, there's a high in arterial cirrhosis. The basement damage and the patient have the albumin.
What is the role of age, that is advanced glycation end products in diabetic nephropathy? What does it do?
Because of lipid peroxidation, sir.
Okay, lipid peroxidation is one method of formation of advanced glycation end products. Lipid peroxidation and non-enzymatic combination of sugar with amino acids or lipids. But after the formation of this AGEs, what happens? How does it produce renal damage?
Yeah,
They get eliminated or excreted in the urine?
no,
Yes,
sir.
sir.
Do they cause damage to the tubular cells? That is how the kidney damage. The nephropathy, what happens is this advanced glycation end products, they get filtered by the basement membrane in the glomerulus and they enter the proximal tubule. And once they come to the proximal tubule, they cause an inflammatory reaction which affects both the tubular cells as well as the vasculature that is subserving the nephron. Okay, because of that only the diabetic nephropathy is microalbuminuria happening as a first indicator of diabetic nephropathy. The quantum of microalbumin increases to more than 300 milligrams per 24 hours. And then gradually the filtering capacity goes up and patient goes in for diabetic nephropathy. So the three systems that you have to evaluate before you take up any diabetic patient for any particular surgery is rule out any cardiovascular involvement, rule out any neuropathic involvement, rule out nephropathic involvement. Okay, if these three are okay, then the patient will not have any problem. If these three systems are already affected in a long-standing diabetic, then these patients are likely to have a lot of trouble in the postoperative or intraoperative period. And if there is a neuropathy already present, these patients may not withstand a single shot spinal anesthesia properly. Why?
Because because of the sympathetic function already lost, so they are more prone to hypertension during injection.
The hypotension that develops after a single shot spinal will be very, very difficult to treat in a patient with already existing diabetic neuropathy. So better not to administer any central neuraxial blockade. Even epidural may be not very safe in them, and go for general anesthesia where you can support with the intact nervous. So that is all the problems that we have to think of in this case. I will just go through some of the important slides that you can see in this.